This week on the BackTable podcast.
One thing that I've learned, and I always talk to my patient day one, I always talk to them every day, but on day one, and I reiterate it on day two, I explain why I want them to do what I want them to do. That is actually really important. And maybe that is an obvious, thing, but if you really think about it, I think my prior practice was like, hey, we'd like you to walk 3 times a day. Okay, we'll come and check on you later. I really left out the why, but I think the why is really important. And I explained, hey, listen, I know it's going to hurt to get up to walk. I understand that. But here's why. I want to reduce the risk of pneumonia, which you're at risk for. Want to reduce the risk of DVT, which you're at risk for. And all of these things can be reduced just by you getting out of bed a few times a day. And likewise, for incentive spirometry. And the interesting thing is once I started saying that, my patients were much more compliant on doing them.
Hello, everyone, and welcome back to the BackTable Urology podcast, your source for all things urology. You can find all previous episodes of our podcast on iTunes, Spotify, and at BackTable.com. This is Aditya Bagrodia as your host this week. This is part 2 of a 2-part episode on peri-operative optimization of cystectomy candidates with Dr. Angie Smith. If you haven't yet listened to part 1, I encourage you to check that out as well, as we're now going to pick up on the conversation right where we left off. All right, great. So maybe perhaps moving a little bit more to the short-term peri-operative period. We've kind of been talking about call it the weeks and months leading up to surgery. Now we're getting really, really close. So the first couple of days, prior to surgery, are you doing anything like pre-operative incentive spirometers, immuno nutrition, any other kind of considerations?
Yeah, so we do have good evidence now regarding nutrition. I had mentioned we always have a nutrition consultation in the pre-op period. Ideally, we have it before chemo, and then we might have a repeat assessment. Pre-operatively, we actually have a post-operative assessment as well. But in that, there's some good evidence for the use of immuno nutrition, particularly in cystectomy patients, but other major surgeries as well. And, there's also the thought of, and it's sort of part and parcel, there's the thought that carb loading can be helpful in the day before surgery, essentially. But, I've been sort of following the literature. I don't do research in immuno nutrition myself, but Jill Hamilton from Kansas is sort of leading the charge in that. Has done some excellent studies that confirm that immuno nutrition does have an impact. And the idea behind immuno nutrition is that that during times of stress, surgery, that there's particular proteins, that and demands and of the body that change. And because of that, immuno nutrition can assist with wound healing and so forth. So essentially decreasing immunosuppression. She's done a study that it showed it increased lymphocyte count, for example, and it modified systemic cytokines. So there's like good science behind it. And the idea is you give some kind of oral supplement that in a lot of, I have no stock in this. So, for the purpose of podcast and just practicality, a lot of people use Impact for this, but essentially it's like has nutrients like arginine and glutamine and some fatty acids. It's commercially available. It's actually pretty low cost. And you give it for about 3 to 5 days, something like that before. And some recommend before and after surgery. We do it before surgery for a few days. There's some good evidence in the colorectal literature that it has led to a significant decrease in postoperative complications. So it's not like this is like voodoo science. There's actually good evidence it might be beneficial, and there's not really a lot of downside to it, right? So we do that. I'm curious what you do in your practice as well. We do a little bit of carb loading in the 24 hours prior to surgery, and it's driven by our nutritionist who, as I mentioned, sees every patient. And then your other question was regarding preoperative incentive spirometry. So I think there's less evidence here, but it's one of those things that makes logical sense. It doesn't have a lot of harm, particularly anybody like, let's say, smokers. Even if, you just touched upon smoking cessation, we definitely incorporate that in our ERAS protocol well before surgery. Everyone gets a consultation with regard to that. But those are the patients, right, that preoperative incentive spirometry may be even more beneficial, in my opinion. And so we'll do that for certain patients. I wouldn't say everybody is recommended to do it, but there's not a lot of harm. So, I think that that's a sort of a logical way that you could, get patients motivated and sort of invested in their own recovery. So I actually could see, as I just speak out loud here, that there would be benefit in just kind of like getting them on board because they're going to be doing that in, after surgery, have them practice beforehand. So maybe that's something we should be doing routinely. So what do you all do?
So we've kind of recently, kind of on the heels of the pandemic, explored a same-day surgery prostate protocol, and that's kind of got incentive spirometers. And we're thinking about incorporating more standard into the ERAS cystectomy protocol. Immuno Nutrition, we were trying to open the trial, which I think was Jeff Holzverline and Jill Hamilton, as you mentioned. And I think, you're spot on. I just tell them, I think it's Nestle, right? Nestle
It
Impact.
is. Mm-hmm.
Yeah. So I'll just say, go to your Walmart or CVS, pick up like a case and, start working on it. It's not really kind of codified, if you will, but I'll try to remember just to mention that to them before. So otherwise, quite similar to what you mentioned. How about bowel preps? Are you all doing much by way of bowel preps?
Historically, I think, bowel prep was something that we did. In fact, when I was training, we were doing it earlier in my training. And then there was a pretty big paradigm shift after that. There's a Cocker review. It's like in early, maybe like 2010, 2011, it came out. They basically showed that there was no difference, particularly among those who underwent colon surgery, no difference in anastomotic leaks or wound infections, et cetera, which was why the mechanical prep was instituted. So I think in urologic surgery, we don't do any mechanical bowel preps. I mean, maybe we might do an enema to debulk the rectum for a patient who had prior radiation. I don't even standardly do that, but I don't see a big downside to something like that. There's also the oral antibiotic prep, and I think for colonic surgery, it could be considered. There is still some evidence that maybe there is benefit here, but it's not been studied as well in urologic surgery. I mean, we don't use the colon often. We use the ileum. So, I would say, if you're asking me just what do I do, I don't use bowel preps in cystectomies. And, I'm not sure if I could say that for everyone, but I think that there's not great evidence for its benefit. And you have to remember, whatever we do, the patient has to do it. I feel like I need to have a good reason to put them through something like that. And if I don't, then I don't want to, contribute to any challenges they have in the perioperative period. It's hard enough to undergo a cystectomy. So I don't see a lot of benefit there. What about you?
Yeah, pretty much agree. I mean, it's actually I say silly. It's a thing that can be some source of confusion in the few instances it's required. It's like, well, do I do it after I eat or before I eat? And,
Yep.
then maybe they're up all night running to the bathroom right before a big surgery, just coming in
And
fatigued. So
dehydration, right?
absolutely. Yeah. I tell them, never tell somebody not to drink something for 12 hours and then, basically get themselves dehydrated before like a half marathon, which is
Right.
kind of what I like in this too. So pretty much on board with that. Maybe it's my own paranoias, but if they've had a radiation for prostate cancer or something, God forbid they would have a rectal injury, I
Yeah.
do an enema prior. Almivipam, is that kind of standard for you all?
It is. We know there's like level one evidence for this, but I think it's still controversial because there's this belief that, oh, if you have opioid sparing type of program, you shouldn't need alvimipam, right? But I will say, like you, I mean, I trained at a point where we didn't have it, and then and even was in practice when we didn't have it, and then transitioned to using it routinely. And my ileus rate has gone down dramatically, dramatically. And perhaps that's anecdotal, but like I said, there's level one evidence too. So we use it routinely. I am a big believer in it. And I still use opioid sparing protocols. So can I explain it exactly? No, but I will say that it's been very helpful in my patient population for what it's worth.
Same here. Kind of wholeheartedly echoed that. It was really at the end of my residency that almivipam kind of came on the scene. And I feel like if I take a walk down memory lane, it surely seems like the rates of ileus are improved. What about preoperative heparin, Lovenox? Is that standard for you all?
Yeah, we do a single dose preoperatively, as a matter of fact, on everyone. So they get it in the holding area before they come back, and And then, of course, we continue it after surgery. I like to start with subcu because I guess you could say it's a little bit shorter acting, right? If there's a bleed in the first day, maybe that's again voodoo science, but it makes logical sense. And then I switch it over to Lovenox the day after that once I feel like, okay, they're doing all right. But yeah, we routinely use it. And even if I have a patient with cardiovascular disease on baby aspirin, I'll do a cystectomy on a baby aspirin. I haven't had any issues with that.
Yeah, I kind of share that voodoo myself. And honestly, it kind of takes out any renal insufficiency considerations and so forth,
Yes.
making it kind of smooth to get those order sets in. All right. So maybe if I just like kind of briefly recap in the several days up to surgery, Immuno Nutrition is something you all do. Incentive spirometers, maybe not, depending on smoking status. NPO, is that going to be generally no solids 8 hours before? And then we have them have a Gatorade 2 hours prior, as long as
Yeah.
they're not diabetic. There's other, you could say, more medical prescription level fluids, but I think a Gatorade's pretty easy to navigate for patients. Oh, the other thing that we do is we'll typically routinely get 1,000 milligrams of Tylenol,
Mhm.
some ibuprofen, and then
Mhm.
we've actually moved away from gabapentin over the course of even my 5 years as an attending.
Yes.
I think the literature has kind of flipped that may not be the best option. And I can say anecdotally that, sometimes the confusion, the lethargy is pretty pronounced.
Yes, it's interesting. We've actually done the exact same thing. We had gabapentin as part of the process. There was some early evidence that like the preoperative dose was helpful, but and perhaps it's because our patients are older. Maybe they're more sensitive to the drug. We've sort of moved away from that now, but we also we agree. I mean, Tylenol is a great drug. We use it routinely and can be really helpful in that multimodal pain regimen.
Perfect. And what about muscle relaxers? Are you using those?
So I think it depends on the patient, and the anesthesiologist. I will say that our anesthesia teams have their own sort of ERAS protocol that they sort of institute over time, like iteratively. I will say that they certainly, and just sort of skirting around your question, but I think that the question's more about like what do you use, right? Is that there's a protocol that every cystectomy sort of a week ahead, there we're asked essentially if we want an epidural, yes or no. They all think about ketamine. I don't know about your group of whether they think about that,
Yeah.
but
Hmm.
ketamine is sort of one of their go-tos to reduce opioid use. The other actually pretty common multimodal strategy they've been using is lidocaine infusion, which has been helpful. And then, they do some other things to try to avoid postoperative nausea, vomiting. It's not necessarily anesthetic related, but rather things that, just help with that process, dexamethasone being one of them. But, yeah, there are some other types of, you could go down the rabbit hole of like the epidural
Sure.
analgesia, whether it's like the, local anesthetic with opioid or not, or intrathecal opioids, like all of those types of things. But in general, we have the anesthesiologist to discuss. There's also, some other peripheral regional blocks, like the transversus abdominis plane blockade. I wouldn't say we use that routinely. I do a lot of robotic cystectomies. And honestly, pain isn't a big issue, and that's I think maybe that is the biggest take home point is that we think of it as a big operation, and it is. There's no doubt, but that doesn't mean that is an operation that has significant or tremendous amount of pain. I think a lot of it can be managed with scheduled Tylenol, NSAIDs, things of that nature. And most cases, we can get by with minimal opioids. I mean, we use it for the first day or two, and then after that, we can actually almost routinely, dial down the opioids very very quickly. What about your practices?
Yeah, I would say it's exactly similar. Tylenol and ibuprofen or Toradol in-house kind of provides the backbone. I think it's more of a practice pattern thing for us. It is tap blocks versus epidurals.
Mm.
And I would kind of maintain that I think the benefit, especially if you have like a 2-3 centimeter periumbilical incision, is probably pretty marginal. Yeah, I mean, I kind of totally agree, and I would say it's kind of outside the scope when you limit fluids intraoperatively and close monitoring of the various output parameters. How about things that you, let's just say, try to be fastidious about or teach to the fellows and the residents, at the level of the surgeon when you're actually doing the operation? I mean, expeditiously, to careful tissue handling, minimizing blood loss, etc. What are your kind of Angie Smith pearls for the residents and fellows?
Yeah, I think that when we perform procedures, there's a few considerations. So it's the procedure itself, what you're doing, and also the time that it takes to perform the procedure. Sometimes we minimize that time issue, but I think it's something to consider. And the reason I say that, and that's probably one of the pearls that I want to, that's why I'm kind of speaking about it, perhaps because my husband is a neuropsychologist. So I think a lot about postoperative cognitive dysfunction, but we don't talk very much about it as surgeons. We really don't, but it exists. And the people who are going to be most susceptible are basically cystectomy patients. So they're the patients who are 70 and older, have a longer operative time. So I actually think about that, and we circle back to the beginning of the podcast. You asked me robotic and open. If I have a patient that I do have some significant concern about that, I might do it open. I know I can go do it a little faster than robotic, and I do it that way so I can minimize the time under anesthesia. I also think about, lymph node dissections. We perform lymph node dissections, but we don't have great evidence for the benefit of standard versus extended. And I think a lot about that. If, an extended node dissection for a younger patient, I'm going to do it. But for an older patient, I think actually it's much more important for them to get off the table quicker to avoid the postoperative cognitive dysfunction, because a lot of them, their goals, their quality of life is really all about trying to reduce or trying to get back to their normal quality of life.
Got it. Got it. I think that's spot on. So we've gotten him through the operation. Can you kind of just walk us through broad strokes, typical patient, what post-op day 0, 1, 2, and 3 look like? Maybe specifically with respect to diet, fluids, incorporation of PT, OT, and drains.
Yeah, drains. Yeah, these are all this is all works in progress, I will say. But I'll tell you what we do currently. Now we've sort of really pushed the envelope in terms of early enteral feeding. So I would say when I first began, it was, maybe sips on day one. And then, but now we really go almost straight to clears. And then the next day we go to regular diet. We actually push it pretty quickly. Now, if a patient is not doing well, has nausea or bloating, and we'll keep it on clears and we won't push it. But if they're doing well, there's no reason to withhold it. And I think there is some good evidence for early enteral feeding. And I think that it helps with the patient as well. So we tend to do that. It actually simplifies the process. Patients are happier, and for the most part, it works pretty well. The last, I mean, and this is, I think, attributable to alvimipam and other ERAS protocols. But the last maybe 2 or 3 cystectomies I've had actually were kind of ready to go home on day 3. I wasn't brave enough to send them. So I made them stay. I said it was one of those days to, practice being at home. But yeah, they're doing well with this early refeeding protocol. So that answers that. We also do pretty standard PT/OT evaluations. I don't see a downside to that. At the very least, they get some exercises out of it. I told you I'm a big believer in PT, whether it's pelvic PT or perioperative PT. And at the very least, they can, get some information like, hey, when you go home, why don't you do these exercises? And it gives the patient something to do. It also prompts them to walk. One thing that I've learned, and I always talk to my patient day one, I always talk to them every day, but on day one, and I reiterate it on day 2, I explain why I want them to do what I want them to do. That is actually really important. And maybe that is an obvious, thing. But if you really think about it, I think my prior practice was like, hey, we'd like you to walk 3 times a day. Okay, we'll come and check on you later. I really left out the why, but I think the why is really important. And I explained, hey, listen, I know it's going to hurt to get up to walk. I understand that, but here's why. I want to reduce the risk of pneumonia, which you're at risk for. Want to reduce the risk of DVT, which you're at risk for. And all of these things can be reduced just by you getting out of bed a few times a day. And likewise, for incentive spirometry. And the interesting thing is, once I started saying that, my patients were much more compliant on doing them. Go figure. I mean, it makes sense, and perhaps that was an obvious thing to have been saying. But when you do it day in, day out, these are the things that maybe you take for granted, one takes for granted as a surgeon. So that's much more important to me. I talk to my patients about it. And then I think the last question was about drains. So I think there's a few, so it depends, right? So let's say we're talking about an ileal conduit, then I always have stents in for that. And then I'll have a JP drain. I tend to remove the JP drain basically the day before, day of their discharge. And I don't typically send a JP creatinine unless I have some kind of concern. It's very rare to have a leak, but I'll, do it. I leave it in for a couple reasons. One, if there's a urine leak, although that's rare, or if there's some kind of bowel leak, also rare. I will say that one of my colleagues, actually just last week, he announced, he's like, you know what, I'm going to take the drain out on day one because we don't have leaks. And I'm just going to send a JP creatinine right then and there and then take it out. And I'm not brave enough to do that yet, but I think it's reasonable. And his reasoning for that, because you always have to have some reasoning, is that, that drain is just another tube out of their body that might bother them. We know, right? You have that in there. How often does your patient talk about it leaking around that drain site, right? So it's not a benign entity. So I think it's reasonable to consider, why do we have it in the first place? And then regarding stents, I leave those in for about a week and I've gone back and forth. Some people leave them in for longer and I used to do that. What I found was that I think with the biofilm that forms, I had a higher rate of infections when I would remove the stents, even if I use peri-procedure or peri-tube removal antibiotics, which I do 3 days, I do day before, day of, day after, which many do. But I still was having a lot of infections with that. So I actually moved it way up to just 1 week. I see them 1 week after surgery because I usually typically go home day 4 or 5, and then I see them at day 7 or 8. And I just remove it at that point. And I haven't had any issues. And I've had a lot less infections. So that's a lot. But I'm happy to answer any other questions about it. But I think that's like the general post-operative, peri-operative standards that at least I use right now.
Yeah, a lot of that resonates. I mean, I can read ERS protocols that say drains out post-op day one, and you look back and you haven't had leaks, but it's a tough sell to take them out a little bit earlier, recognizing that it can be like a protein sump or that they're another avenue for fluid loss. But I'm kind of in the same camp as you, and we do stay pretty aggressive in terms of clears the evening of surgery and the post-op day one, advancing to a regular diet if they're lacking any symptoms of reflux or bloating, distension, etc. So we're kind of on the same page there. If they have nephrostomy tubes in, how do you typically manage those?
Yeah, I tend to take them out pretty quickly. I don't take them out at the time of surgery. And the reason for that is I want to see what things are looking like. So, and it kind of makes sense. It's sort of like a stepwise maneuver that just uses logic, which is, during the case or, sometime at least by the end of the case, I just clamp the nephrostomy tubes. And then the next morning, as long as they're proving themselves to have good urine output through the stents, then I remove them. I try to not to use too much, unnecessary procedures. You can certainly do it under fluoroscopy, but I just say, hey, listen, just have a hold, one person just hold on to the stents and the other person just pull the nephrostomy tube, in that rare case that they're intertwined. And I haven't had any issues with regard to that. So I tend to do it quickly. And the reason for it is, again, it improves their quality of life significantly. They're much more likely to get up out of bed and walk if we get those tubes out. And what do they need them for if the stents are in, right? And then there's urine output coming out of it. So I think it's a reasonable thing to do. At least in my practice, that's what I try to aim for.
Yeah, I think absent any type of tenuous anastomosis, et cetera, would generally agree. So as, patients are kind of meeting their milestones, feeling good, they've been assessed by PTOT, and it sounds like it's reasonable for them to go home. Of course, there's inpatient rehab, stiffs, et cetera. So when they're going home, you mentioned the peri-tube antibiotics. What other medications are you sending them home with?
So we will give a small prescription for opioids, but it's not very much. It's about a week's worth, and it's pretty standardized. We typically give 4 weeks of Lovenox for our patients as well. That's pretty standard, although with regard to financial toxicity, we do individualize that because it can be quite expensive for some patients, and we don't want to bankrupt them because of Lovenox, for example, right? So we think about that. We give the 3-dose antibiotic that we had mentioned. In terms of others, there's not a lot of good evidence for colace. So we actually did away with that. There's actually a really good Cochrane. It feels weird not to give it, right? Because it's sort of embedded in our belief system. But rather than that, we just talk about hydration. I mean, it's all about hydration. And in that regard, I don't do this routinely, but I'll take a look at their bicarb level. If I feel like they have some developing or already present metabolic acidosis, I might consider giving them sodium bicarb. I know I'm not the only urologist in this country who does that, but I have found that it's helpful because it can, I think that it helps patients avoid that. I call it the spiral, because when they get metabolic acidosis, it basically begets dehydration, and then they get a little nauseated. Now they're not going to drink. And it's this spiral that then worsens the acidosis, right? And that often is what leads to readmission. So if I can give them some sodium bicarb prescribed, at least in the short term, that can sometimes be helpful in preventing that. And again, I really, really emphasize the need for their own hydration. I actually don't emphasize as much eating, because I think a lot of patients believe like, oh, I need to eat, I need to eat. It's like, really, you need to drink. You need to have fluids and, electrolyte rich fluids. And that's enough, at least for the first few weeks. And I would say that's, I'm sure I'm missing something. I'm trying to remember anything else, but I think that's the takeaway in terms of what we prescribe. And then, of course, some Tylenol and ibuprofen and all of the other multimodal over-the-counter regimens.
Yeah, really, really similar for us as well. We've actually gone to apixaban, 2.5 milligrams twice daily, just, because a total patient comfort thing, not having to mess around with the shots. And we worked with our pharmacist and we're able to get it approved. And it may actually help out with some of the financial toxicity, something to consider.
That's a
Sodium
great
bicarb,
consideration.
yeah,
I'm going to add that into our protocol.
sodium bicarb fairly routinely for neobladders, kind of case by case, but 100% agree with that spiral of, this little low level nausea, decreased PO, and so forth. I think it's really wonderful that you see the patients, just a few days out, where you're going to definitely get a sense of, are they thriving or are they failing to thrive? And I'm guessing that really helps out with nurse calls. Do you'll have your nurses kind of touch base, or are there hotlines for the patients, at any kind of given time points?
Yeah, so we have multiple things in place. So our hospital, in and of itself, they have a team who always calls each discharge patient, not just cystectomy patients, just any discharge patient, within 48 hours to check on them. A nurse does. And that's been helpful because, there's many times I'll get some information that I did not know that I can act upon. So I think that's helpful. We have a specific triage nurse, and so they're given that number. And that's what she does all day, every day. And God bless her. She's, just absolutely wonderful and patient, very knowledgeable. And essentially, she's there to answer these questions. I will say also, one of my own areas of research funding is in mobile health technology. And I do believe the way of the future, or so to speak, and perhaps the future is now, is using mobile health technology to help recognize these potential issues of like dehydration or pending infection, things of that nature. And it can be done in a way, and in that these apps, and they exist. There's multiple that exist. Some hospitals already have them in place. We're doing it more on an investigational level through my research, but there are other healthcare systems that actually use it. And they use it for ERAS, so pre-op, peri-op, and post-op. But the idea is that, especially in the post-op setting, that every day or every few days, the patient gets a little educational piece of information. They're asked a few very pertinent questions, for example, like fever or wound, infection, erythema, etc., or dehydration, intake level. And if their response meets a certain threshold, then that is then punted to the triage nurse to contact them and find out what's going on. And I think that's, really the way that we probably need to be considering post-cystectomy care, because not every patient's going to be at risk for these readmissions. We want to best use our resources in a way that identifies those at highest risk and then intervene in a timely manner. And that's one way that we are trying to do it. It's not in prime time yet, or for prime time yet, but it's something that we've been working on. And then I should also mention that we, almost for everyone, not everyone, but I would say 80%, and we leave it up to the patient, we usually get home health involved. And we do that actually, we get that started on post-op day 1. So it's just ready to roll when they leave. And I think that's actually quite helpful because it's just one more touch point. Someone who can look at the stoma if they have an ileal conduit or even a neobladder, either way, I think it's helpful to have someone knowledgeable looking at it in between when they go home and in between the time that they come and see me. And then finally, we have what's called a survivorship care visit, and that's at 6 weeks for everyone. And at that point, I always get an ultrasound because it gives me a sense of whether or not there's a potential pending obstruction going to occur. Because how many times have, maybe I should just put my own hand up here, but how many times that you get a stricture and, you only know it's a stricture because they present with a febrile UTI that required a readmission and potentially perc nephrotomes emergently. Well, it'd be great to actually intervene upon that prior to that. And I think that visit's very helpful as a touch point, not only to evaluate for potential, impending strictures, but also just to talk about how they're doing. Because usually at 6 weeks, that's a turning point for patients. And if they're not turning, then now what other kind of resources can we offer them to help them along the way?
Yeah, I think, I would summarize that as it makes total sense to keep your finger closely on the pulse, where they're not going to, be at home failing to thrive. And, they come in a situation that requires a significant amount of work to turn them back around and get them back on the straight and narrow. Well, Angie, this has been an absolute tremendous amount of information. I feel like I keep picking your brain for hours. One random question I wanted to get in there as we approach an hour is female patients with persistent vaginal discharge. How do you handle that?
Yeah, it's a great question because I certainly have had some patients with this issue. So when I have that, I mean, the very first thing I will do is an exam, and maybe that's obvious, but I think it's actually really important because you want to make sure that the cuff is closed. You want to make sure that this isn't something else beyond just vaginal discharge rate. I think the character, and then secondly, I think the character of the vaginal discharge matters. Actually, is a really excellent example. This maybe 2 weeks ago had a patient come back. She had stage 4. She had a cystectomy. I actually did an anterior vaginectomy and just, she's an older patient, just reconstructed the vagina. And she just recently had some additional vaginal discharge. It just seemed out of the ordinary. The character of the discharge had kind of changed, almost like I thought maybe there was an infection. But because of her advanced disease, I always am a little concerned about recurrence. And so we ended up scanning her, and she does actually have a recurrence there, even though she had negative margins. So I think if you have this persistent discharge, important to, to consider that. And sometimes it's benign. Okay. Sometimes it is. And it's at these points that I actually have really wonderful gyn-onc and urogyn colleagues, and I'll have them evaluated. Doesn't happen that often, but that's when I get them involved because sometimes they'll have some ideas that I hadn't thought of. But in general, that's my process by which I sort of go down the path of managing that. I'm curious what yours are because I don't know if there's like a tried and true method for this.
Yeah, I think early on, barring anything intraoperatively that was concerning, et cetera, the small several milliliters, I think that generally will cease as they get out, 4-6 weeks. But if it persists 100%, it's a vaginal exam, just making sure there's not any small dehiscence. I recently had a patient, it was interesting, it was a urachal adenocarcinoma with a drop met to the posterior vagina and had to do a complete vaginectomy. The vaginal cuff came together quite nicely, and she had some persistent discharge that was a little bit higher volume that I would like to see, just, peritoneal fluid seeping out from some, small little areas between the sutures. But I did an exam, and that's precisely what it was, just a little pinpoint area. And, I counseled her on just a little bit more time. But generally, I feel like they resolve without too much of an issue. It's going to be the one-off where it may be, pretending something a little bit more different. But, I think your last comment on even touching base with urogyn really captures the theme of this entire episode, which is it's a team sport. Of course, we're in it as surgeons. Then there's anesthesia, nutrition, smoking cessation, physical therapy, hospital level folks calling the patients afterwards. And it really, I think, takes a village to safely get these patients through this, massive, massive experience. So with that, love to hear any parting thoughts, Angie. And, thank you again for your time.
Yeah, well, thanks again for having me. I think that maybe the parting thought that I would leave everyone with, and I should have probably mentioned at the very beginning, is, if anyone wants to read more, and I would encourage you to do it, because that's how we change our practices. And, even this conversation, there's two takeaways that I'm going to be, potentially changing in my own practice. It's learning, and one great resource that I had the privilege of being a part of is the AUA white papers on peri-operative management and optimization in surgery. And so they're really nicely split into, pre-operative management, intraoperative management, post-operative management, and perhaps more than anybody would ever want to read about it. But I do think, just kind of perusing it is really helpful, whether you're, new in practice and want to develop some kind of EROS protocol as you begin, or if you've been established and just thinking, we can do better. Let me see what we can do and incorporate in our practice. I think it's a great resource. It's free, it's online, and it's current. So I've actually learned a lot just being a part of that project, things I had not even considered or known about. So I think my parting words is to, just stay curious and to always question what we do and how we can improve. Because I think that's part of the fun of medicine. And I think there's probably no better way to do that than through things like enhanced recovery after surgery and patient-centered clinical care. So again, thank you for having me. It's really been a pleasure having this conversation with you. I've really thoroughly enjoyed it.
Thanks. Yeah, I've actually read that paper. It's excellent. And, one last thing, maybe if you're doing cystectomies, regardless of the volume of your hospital, don't be intimidated. That's a perfect document to give a read. Touch base with your anesthesiologist. It doesn't need to be a complete 1000% overhaul at time point zero. Start with the little things that you can do and build a program. All right, Angie. Well, thank you so much for the wealth of information. I certainly have learned a lot over the last 2 episodes, and I'd like to thank the BackTable Urology listenership for tuning into the podcast. Until next time.